Anyway, we propose treatments, non-pharmacological treatment, most often, sometimes pharmacological treatment to our patient, and this is an ethical duty to know if these treatments are correct or not, and correct means evaluated by science. And of course, this is a tricky thing, as you know, because when you propose a treatment to a patient, and this is not only in child and adolescent psychiatry, this is in medicine in general, this is very difficult to know. Even after you gave the treatment, this is very difficult to know if it works or not, because sometimes patients feel better alone. So we have to do, so my conflict of interest, I love this topic, and so I work a lot with many people about that. And so in particular, I know how medication are evaluated. Something which is very important comes from history. And for that, there is a very good book written by Harry Marks, The Progress of Experiment, Science and Therapeutic Reform in the United States during the 20th century. This is very easy to read, and for me, this is the best book that studied the evolution of evidence-based medicine in general. But at the very beginning, so in the 19th century, essentially, in fact, statistics were not used, and in fact, statistics didn't exist really at that moment, and it was biology that was at the core of evidence-based treatment. And you know that pathophysiology emerged at the end of the 19th century, and pathophysiologists said that you have to find the cause of the disease, then you have to find something that act on the cause of the disease, and then the patient will be treated. It was theoretical. And it was experimental on animals, not that much on human beings. And it worked somewhat with antibiotics and with vaccine, a couple of decades after. And so this is strongly rooted in the mind of physician. Mechanism of action. We need to know mechanism of action of treatment to be sure that they are effective. Of course, in fact, reality is more complex like that, and at the middle of the 20th century, scientists realized that many times we don't know the cause of the disease, and many times we don't know why the medication treats the disease. And so they realized that they had to be humble, and that this biological way is interesting for germs, for bacteria in particular, but for lung cancer, for instance, you know that tobacco is often the cause of lung cancer, but this is not because you know that you can treat the patient. It is valueless. And so they asked themselves, what could we do? And they decided to do randomized controlled trial because 30 years before, Ronald Fisher wrote that to study plants, which type of crops is better than the other, he proposed to do randomized control trial, which was not obvious at all. We could come back about that. Randomization is not something obvious because if it is random, if you randomize groups, perhaps by chance, the groups will be different. And when Fisher proposed to randomize, everybody said, no, you don't have to randomize, you have to pair. You know? If you do a pairing of patients into groups, the groups will be similar. If you random, by chance, they can be not similar. And so randomization is not something absolutely obvious. Anyway, it works on a statistical point of view, but this is quite tricky. And so they decided to do randomized control trial. They decided like that. And it is in 1962 that in the US, for the drug the Food and Drug Administration. Before 1962, the FDA had only the problem of safety of medication. Do you know how they decided efficacy of medication? A drug was efficient when it had an economic success. This is written in the FDA, and so which is not stupid. If it has an economic success, it means that doctor use it. If doctor use it, it is likely that it works. But of course, advertising is also a confounding factor. And so in 1962, they said, no, economic success is not enough to decide efficacy. And so the senator, Kefauver was a senator, and Harris a representative, and there was a trial and arguments, and they asked two experts, what can we do to evaluate efficacy? And experts said, randomized controlled trial. And this is funny because it means that randomized controlled trial never proved that it is an efficient methodology. The level of evidence of randomized controlled trial is very low because it comes from expert opinion. It does not mean that randomized controlled trials are not a good methodology. It is a good methodology. But it is a good methodology just because we know it. But there is no evidence of it, and it would be extremely difficult to show that. We could randomize country and propose that in some countries there will be randomized controlled trial and the other observational study, and to see blah, blah, blah. No, this is just impossible. You understand what I say? Okay. And so randomized controlled trial have been imposed by FDA, and so at that moment there was randomized controlled trial everywhere. And later, even if evidence-based medicine emerged before, but the concept was published in 1996, which is not middle-aged. This is quite recent, and this is the definition that you know. And this is, evidence-based medicine is at the intersection of available evidence, but also patient preference and value, of course, but also, and many of administrative and politicians forget it, professional expertise. This is evidence-based medicine. This is the three: evidence, patient preference, and professional expertise. What happens after? And here is a paper that deal with evidence-based medicine during the 21st century. In fact, there was a randomized controlled trial everywhere, but not only on medication, in general, for everything, for non-pharmacological treatment, even for public health intervention, for prevention intervention, and even for management. And you know that in health economy, they do randomized controlled trial nowadays. And so it has been a complete success, and it has been some kind of sacralization of randomized controlled trial, and thus of evidence-based medicine. And I am sure that if in your department you say, I fuck evidence-based medicine, everybody will see you and no, this is like, this is a sacrilege. This is something that you cannot say. Anyway, sacralization is not good in science, you know. Anyway, and because there was sacralization, because it was too much, there is today many crises about evidence-based medicine. First, there is a crisis about statistical inference. To be clear with that, you know what is p-hacking? P-hacking is when you want to publish a paper. For that, you need to have a p inferior to 0.05, and then you are trying to look for all the statistical methods that you could use, and you will pick up the one that lead to p inferior to 0.05. This is a major problem all around the planet in medical research and in research in psychology. This is a big issue. And most often, people don't realize that they are, in fact, doing a fraud. And why they don't realize? Because, in fact, today, you know the software R, which is a statistical software. It is free. It is extremely powerful. It is as if everybody could have, for free, a Ferrari. But if you don't know how to use a Ferrari, you will have an accident. And this is exactly what happens with statistical software today. So crisis of statistical affair, crisis of randomized controlled trial, because you know that generalizability is not good, because there are inclusion criteria very strict, because randomized controlled trials are not good to study side effects. Statistical power is never determined for side effects, so we don't know side effects. Outcomes are rarely really clinically relevant, because good outcomes need a huge sample size, etc., etc. And there is also a crisis of evidence-based medicine itself. First, there is a misuse of evidence-based medicine. Second, today, the problem with treatment is efficacy, but it is more money than efficacy. And it is easy to propose a treatment that has a certain level of efficacy. But to show that it is cost-effective, this is much more difficult, and randomized controlled trials are not used for that. It is health economy. Biologists, CAR T-cell, you know CAR T-cell treatment, very sophisticated treatment that are used for leukemia, etc. 2 million euros, one injection, no randomized controlled trial, just a cohort without any group of comparison, just because of the mechanism of action, like in the 19th century. And we pay for that. And we have not 3,000 euros to deal with an adolescent that committed a suicide attempt to the emergency department here. We have not 3,000 euros. Why we can give 2 million euros for a CAR T-cell? And there is no data for that. No data. And there is a question of psychotherapies. And so this is because perhaps it is not so easy to evaluate psychotherapies like to evaluate medication. And just in 5 minutes. In front of this crisis, there are new methods that are promoted at the moment. That there is a lot of creativity about evaluation of treatment. Qualitative research. There was Andres Martin here. He is co-head of the Qual Lab, which is a qualitative lab that does qualitative research in child and adolescent psychiatry with Lélia Benoit, who is a young child and adolescent psychiatrist from France. End of one study. End of one study are research with one patient, and you. With a smartphone every day, you ask questions, and so you can do statistics. Bayesian design, observational study, data science, big data, etc., 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 and so, what is the specificity of child and adolescent psychiatry for evidence-based medicine? First, we saw that the mechanism of action is important to have a certain level of evidence for efficacy in child and adolescent psychiatry. Even for medication, what is the medication? What is the mechanism of action of SSRI, stimulants? Why methylphenidates is effective in ADHD while it is completely absurd because it is a stimulant. You give a stimulant to a child with an up, and it calms the child. I'm sure that parents of patients already ask you the question, and I'm sure you are very embarrassed to give an answer, because we have no answer about that, no serious answer. So mechanism of action and mechanism of action of psychotherapy. EMDR, for instance, what is the mechanism of action to move A's in PTSD? In psychoanalysis, you have a mechanism of action, but this is somewhat speculative still. So we have not that. So we have only statistics and randomized control trial. But to do a randomized controlled trial in child and adolescent psychiatry, this is very difficult. Why? Because age groups, you know, from 0 to 3, 3 to 6, 6 to 12, 13 to 16, 17 to 25. These are different patients. Depression is not the same, 0, 3, 3 to 6, etc., etc. So you have to do trial in age group, in all age groups. And you have few patients. And parents, they don't like to authorize their kids to be in randomized controlled trial. So it is difficult to do randomized controlled trial. And in addition, our phenotypes, if you do a trial in autism, what is the definition of autism today? A mess. Everybody knows that. Everybody knows that. So it is difficult. And this was for medication, even for medication, this is, but for psychotherapy, this is even more complex. And there is a question that statisticians don't like at all, which is, however, a major question in medicine in general. Statistics only show an evidence for an average patient, but you never treat an average patient. And so, how can you, physician, infer from the statistical results what will happen to the patient you have in front of you? You can ask that to my colleague statistician, and you will see they will look at their shoes because. And so this is just the last point I want to discuss with you, but I think this is very important to realize. Consider this situation: a reproducible treatment, medication, pills are reproducible. Consider a disease that is homogeneous, acute leukemia, you know, it is quite reproducible. Imagine that the therapist effect is small and random. If you prescribe a drug in acute leukemia, whether you are a man, a female, young, old, black, white, etc., the drug in leukemia will work quite the same. And if the patient effect is small and random, that is, it is more tricky, but if you are more or less old, a man or a woman, there can be difference in outcome. But in acute leukemia, if you are 30 or 40, this is quite similar. And so, then you have individual efficacy, which is equal to average efficacy, that is measured in the randomized controlled trial, plus a little noise. And so in this situation, the individual efficacy is equal to the average efficacy. And in fact, you don't have to do randomized controlled trial. You see that it works. And I mentioned as example, you know, in dehydration, if you propose infusion of an isotonic solution, it works. You don't need to do randomized controlled trial to show that. And there are many situations in medicine where we know that it works, and there has never been any randomized controlled trial. Because you do that 5 times, people did that 5 times 50 years ago, and everybody knows that it works. And that's okay. Now imagine that, but this is always a medication, still a medication. Disease is not so homogeneous as it happens in myocardial infarction, etc., in psoriasis, etc. The therapist effect is not so small. You can have good physician. With some physicians, the patient takes the pill. With other physicians, the patient don't take the pill. And so there is a therapist effect. If the patient effect is not so small, age, comorbidities, then the individual efficacy is equal to the average efficacy plus a big noise. But it is a noise. And so when you prescribe the treatment, you have no choice because there is noise and you don't know what is the noise. And you have a treatment that is in average effective. And so you prescribe the treatment that is effective in average, and perhaps it will not work because of the noise, but nobody knows. And so because nobody knows, you have no choice. And so this is where evidence-based medicine is very important. And so I mentioned antipsychotic in schizophrenia, antidepressive in OCD. We know that we have to prescribe the treatment, excepted if new study we say the contrary. Now, imagine a treatment that is not reproducible. For instance, a psychotherapy. Even if it is called a CBT, even if it is supposed to be protocolized, we know that when we film therapists, that in reality, they don't know what they are supposed to do. And not only psychoanalysts, also CBT therapists. And this is fine. This is fine. If the disease is not homogeneous, and ADHD, is it homogeneous? Autism, is it child depression? Even anorexia nervosa? If the therapist effect is important, of course, therapist effect is important. Now, and I really do suggest you to read the paper of Van Polt. I feel that he exaggerates a little bit, but you have to read that because there are data behind what he says, and this is about specific and non-specific effect of psychotherapies. And now we have a randomized controlled trial meta-analysis where we can study a therapeutic alliance, therapist effect, etc., specific effect, technique within the therapist effect, etc., the therapy effect, etc. And this is called component analysis, and he shows that the therapist effect is huge as compared to specific effect. And so and patient effect, of course, patient effect is important in psychotherapy. You know that this is a day-to-day. And so individual efficacy is just equal for a little bit average efficacy plus something that we don't know, and we don't know even if it is some noise. And we are here today. This is much more difficult with the psychotherapy to say we can do that here because it is evidence-based, like with the medication. This is not the same because the parameters at the origin are not the same. And we heard that. In my country, we have recommendation, you should do that in that disease because it is evidence-based. This is not really true. Why? Because it depends of the training of the therapist and not on the therapy. The training of the therapist is much more important than the therapy effect. And how can you know if the therapist is well trained? And this is my conclusion. So medical treatment are evaluated from mechanism of action and RCT. This is reality. And our treatment are penalized because of that, because mechanism of action we have no, because RCT are difficult to do. But there is a crisis in evaluation. But there are new methods that are promoted, and we have to take the opportunity of these new methods to evaluate our treatment in a different way. Because if we don't do that, we will not have any data about the efficacy of what we do for our clinical practice. That's it.